Good morning. I would like to welcome you to the Suicide Prevention Talk with Rachael Keefe. She has been the chaplain at the New Hampshire Psychiatric Hospital, and now she is a minister in Minnesota. And thank you very much for presenting this talk.
Thank you. You will get to know a whole lot more about me very shortly. But I wanted to give everyone an opportunity to express any specific questions you come to this workshop with. Anybody have a burning question you are hoping to get an answer to?
I'm really looking for how to be able to talk safety and sanctuary in the pulpit and with scripture.
Okay. Nice, simple.
Sorry.
That's okay. I expected that from you, Beth. Anybody else have a topic or an aspect of this? Yes.
I'm very interested in the postvention part because we did have a suicide in my congregation and we felt
Okay.
ministered to the husband left behind.
Okay. We'll put you in charge of Candy and outlines. Yes.
So earlier in my life before ministry, my son attempted suicide and was not successful. But now I find that I have a whole host of emotional responses from folks in the congregation who have relatives that do it. So I'm trying to reconcile my own personal feelings about my son and my ministry to folks that are grieving.
Okay. That is a challenge. Yes.
I have a daughter who says she won't, but then rattles around and takes way too many sleeping pills and
Engages in very risky behavior.
yes, and so,
What do you do with that?
and we live 1,000 miles apart, 2,000 miles apart now.
Okay.
I got a phone call 2 months ago from a person who I knew from a previous job, and she said that there had been 5 suicides of youth in their county in the last 2 months, and their church had to do something. And so would I come on October 20th and talk to them? So I'm taking notes.
Okay. I will also tell you that the more extensive version of my outline, which is more pages than I wanted to print off for all of you, will be available in the Dropbox section for those of you who registered for the conference. You got a link to Dropbox for all the workshops. After today, sometime in the next day or two, it should be in that. So that might be helpful to you. We'll go in the back and then in the front.
In my congregation, we have a ton of young people who we are finding that it's a chain reaction where one person does it, so somebody else does it.
We will definitely talk about that. The containing the contagion that seems to happen, especially in youth communities. We'll definitely get there. Yes.
I think my interest is really only since our board meeting in which we talked about this as a sort of almost an entry point into getting people to think about mental health issues in general. Because people care about their youth and what's happening with the youth in their town, et cetera, et cetera. So I see it as sort of a way of beginning dialogue.
It can certainly be that. Just curiosity question for me. How many of you are clergy? Okay. How many of you serve as deacons or congregational care or somebody directly involved in care of folks in your congregation? 1, 2. Okay. Good to know. All right. So anything people want to be sure we talk about in the next hour and a half? Okay. I'm going to begin with a reading and it's called A Prayer for Peace. Where is our refuge and our shelter? We sit in darkness and the shadow of death. War and violence fill our lives year after year. Is there no better way? Lord, in your mercy, guide our feet in the way of peace. We are awash in the bloodstains of judgment and caught in the storms of hatred. Ignorance and isolation separate us day after day. Is there no better way? Lord, in your mercy, guide our feet in the way of peace. We burn with shame and guilt, pleading with gods of our making to offer us forgiveness and life, hour by hour. Is there no better way? Lord, in your mercy, guide our feet in the way of peace. We are lost in the wilderness of fear, unable to recall the prophets of old. We deceive ourselves moment by moment. Is there no better way? Lord, in your mercy, guide our feet in the way of peace. Let us sit in darkness no more. Let us not cling to the shadows of death or destruction or despair for another minute. There is a better way. Lord, in your mercy, guide our feet in the way of peace. I did not write that poem specifically on the topic of suicide. It was more focusing on those who are dealing with PTSD, but there is a significant overlap, as you might already know. Several people have asked me how I got to be the one to lead this workshop. And the somewhat joking answer is I got the short straw. No one else wanted to do it. And that may be that no one else was prepared. I've had a variety of experience around the topic of suicide. When I was in New Hampshire, I also served on the State Suicide Prevention Council, which was the more professional involvement with suicide. But my story goes way before that. I've always said if I write an autobiography, it's going to be called My Life as a Statistic. It's true. More than 30 years ago, I was that kid. The one who was involved in church, went to youth group, sang in the choir, was interested in confirmation class. How many of those are there? And I was also the kid who attempted suicide. And most people were very surprised because I never said much about what was going on in my home life or what was going on in my head. And it was the response of clergy and that congregation after my suicide attempt that really shaped my understanding of myself and what the church can be. Most of us today don't think of the church as a life-saving community. Right? We don't talk about it. Good mainline Protestants don't talk about salvation in any way, shape, or form. But the church, at its very best, embodies the love of Christ in real human ways. And it becomes a life-saving community, literally. Spiritual salvation is a whole other story. But the church has the power to save lives. It really does. So our job is then to communicate that. Because people who attempt suicide or complete suicide do it because they do not feel their life has value, or that they have a place to belong, or that there is any other way to deal with the pain and anger they feel. And the church has a very specific answer to all of those questions. Does your life have value? Yes, it does. There is nothing in Christian theology that says anybody's life is worthless. Nothing. Jesus died, not for worthless human beings, but because human beings have incredible value. Who are you? You're a beloved child of God. Where do you belong? In a loving, caring, faithful community. That's my answer to why church, why suicide conversation. Because unlike all the other agencies out of there, we have a different message. Psychologists can talk about the value of your life, but they do it in a different way than we do in Christian community. Other faith traditions can do it as well. I don't know them as well as I know Christian community, so I'm going to talk about that. So in the years since, I only had one significant suicide attempt, but I spent probably the better part of 2 decades what I called romancing death. I thought about suicide a lot. There were people I had promised that I would not, so I didn't. But I thought about it a lot. I would spend a lot of time thinking about how and when, and I would do some of those risky things that, kind of walked up to the line but didn't quite cross it. And at any point, it could have happened by accident, because that happens too. I am happy to say I don't have that struggle anymore. A lot of things have changed in my life. But that's the thing, we never know who's thinking about it. We never know who has a plan, and we talk like we know. And that's how contagion spreads. So the assumption is that there are people even in this room who recently, if not today, have thought about suicide in a passive or active way. I'm very conscious of that, and I hope that you will also be conscious of that as we engage in questions back and forth. Over the course of my career, the question of how does God feel about suicide is one that has recurred in various places along the way, as a pastor, as a psychotherapist, as a clinical chaplain. As a clinical chaplain, I was asked it on a daily basis by a patient, a family member, or a staff. What does God think about suicide? Well, that's a loaded question. And there is no easy answer. So my neutral answer was God is not a fan. God is not a fan. And I will explain as we go on why having a neutral statement is a safer, more protective way of responding to that question, regardless of what your personal theology may be. Because there are protective factors in what people believe around God and suicide that we don't want to mess with. We don't want to confirm them, and we don't want to deny them. So my answer over years of practice has been God is not a fan. So let's talk about something you could do that would be more pleasing to God. Sometimes those conversations went well, sometimes not so well. All right. Anybody have any questions so far? Because we're about to get into a little bit more intense information. You ready? Okay. Suicide, what we think we know. We think we know a lot of things about suicide. Is anybody brave enough to say something out loud that you believe about suicide? There's no judgment, just what are your beliefs?
If we're serious, they wouldn't be talking about it.
That's right. That is the number one myth around suicide. If someone is thinking about suicide, they do not talk about it. That is not true. Some people talk about it, some people don't. Talking about it doesn't mean you're not going to do it. Talking about it may mean you're testing it out. What would it be like to do this if I say it out loud? There's a reason Jesus became flesh. The word out loud. People try things out by saying it. What else? What else do you...
People kill themselves with guns more often than any other.
That has some truth to it. Particularly men. Male suicide is usually with firearms.
Failed attempts are cries for help.
There is some merit to that as well. We are going to change our language around how we talk about attempts and suicide completion, because the idea of failure and success attached to suicide is really a bad thing. That was a failed attempt at suicide. Well, thank God. But who wants to be a failure? And if you're someone who thinks about suicide, you're like, well, this was a failure. Next time I will succeed.
Or it's one more stigma.
It's one more stigma. You failed at suicide. So we try not to use that language, fail or succeed, because we want to shift how people view suicide.
If you talk to people about suicide, and they hadn't been thinking of it up until now, then they might start thinking about it, so you shouldn't ask them that question.
That is also malarkey. Yes, if you think someone might be thinking about suicide, you ask, have you thought of killing yourself? Are you thinking about suicide? If they haven't, they're going to say no. I honestly haven't. If they have, they may say no. And you can judge how quickly that no comes. Or they may say, yeah, sometimes I think it would be great to go to sleep and not wake up. That was my favorite fantasy for years. It's passive, low risk, but still indicates there's something not quite right. So yeah, ask. What else?
This is a statement made by a seminary professor whom I really respected. I'm not sure I'm not going to endorse this statement. But,
Okay.
And I think it was made primarily in application to the after effects of suicide rather than suicide prevention.
Okay.
But having said all that, the statement was, there is always an element of hostility in suicide.
That is true. There is an element of hostility in suicide. Suicide is primarily motivated by pain, which generates into anger. And for some people, often male, there is that I'll show them impulse. Women are capable of it too, increasingly more so, but that has historically been true of men. But there is definitely a hostility in there. Hostility toward self, others, a particular situation. Absolutely. What else do we think we know about suicide?
Suicide and alcohol.
They often go together. Is someone who uses or abuses substances on a regular basis has an increased likelihood of suicide?
They seem so happy and successful.
Yes, some people are very good at masking their inner life because there is a drive toward perfection. I have to look like the professional. And then the voice inside is, if people really knew me, they wouldn't like me at all. So yeah, that's the aftermath. But they seem so happy. Really? How well did you know them? And what did they want you to know about them? Mm-hmm. Anything else? How about suicide in the church? How do we think about that?
Well, we will not say the word.
We don't say the word. Nope. A lot of churches will not say the word in the pulpit. And if somebody says, please pray for my son who just attempted suicide, there's a hush. Or if someone says, please pray for me, I'm having some suicidal thoughts, there's a hush. Yeah.
There's a deep thing I'm just realizing now in the Catholic Church about burying people outside of sacred cemeteries.
Right. The old Catholic belief, yeah, they have. The old Catholic belief is that if you committed suicide, you could not be buried in the sacred ground. There are still some old school priests who hang to that, but that is actually changed. And if anybody's interested, I actually have the contemporary Catholic view of suicide. I wrote it out because there's always somebody who asks, because there's former Catholics in the room. Yep.
Yeah, it's in the culture.
Yeah, it is totally in the culture.
The struggle when doing a funeral for someone who has died by completed suicide, and the family trying to decide obituary words, and the family trying to decide whether to name a piece of the cause of death.
And usually they don't. They usually say so-and-so died suddenly or unexpectedly, and there isn't a mention of suicide. I've seen very few obituaries with the mention of suicide in them. Think how much our sympathy, empathy, knowledge would change if people would acknowledge that. Yeah.
Is that due to insurance sometimes?
Nope. Nope. There's still insurance life insurance won't pay if someone commits suicide, but yeah.
Sometimes if somebody's been acting depressed and you're really concerned about them, and then all of a sudden they seem to be better, you think that they're better. When really sometimes it means they've decided that they're
That's
going to
a
go ahead.
huge red flag, and we'll talk about that when we get to warning signs, but yeah.
It's up to the family if they want the secret kept and not to the church.
It is up to the family, but as church leaders, clergy particularly, we have responsibility to do some education. But yeah, you have to respect the family's wishes, but some education there is often helpful. Yes?
Just that if you're cutting, you're suicidal.
There is that. Cutting, if you are cutting, then you are suicidal. And cutting is a relatively new or frequent phenomenon among adolescents today, and it is not necessarily an indication of suicidality. It is an indication that there is something seriously unbalanced in the young person's life, but it does not necessarily mean they want to die. For some it does, but not for all. What else? Especially around suicide in the church.
Good Christian families don't have suicide in them.
Good Christian families don't have suicide or mental health issues at all. That's right. We have that somehow Christian faith protects you from any kind of mental illness. And if you have a mental illness or you have suicidality or someone in your family has completed suicide, then you've got it wrong. That is sort of a common belief that is not often articulated. That idea that suicide is a sin is something that is held by many people across denominational affiliation, and even those who have no faith tradition think that there is some kind of immortal judgment if you suicide. There's good news in that, because for some people that is the only protective factor. I cannot kill myself because I will go to hell. We don't want to mess with that for someone who's at risk. On the other hand, very few denominations have an official stance that says suicide is a sin. Very few. So, but we tend to sort of that idea that suicide is that one unforgivable sin kind of hangs out in society. Do you know what the unforgivable sin named in Scripture is?
Blasphemy.
What the hell is that? Yeah, no one knows what that is. Truly, no one has any clue what that is, but it is not suicide. I saw a hand over here.
Yeah, I was going to say one of the corollaries to suicide being a sin, go to hell, is that the surviving family members feel, I won't see them again in eternal life.
Right, and that puts them at risk.
Eternal cutoff.
Right. So if you let that belief that my loved one is in hell, and you let that stand untouched, then potentially you have family members who are at risk for suicide because they don't want their loved one to be alone in hell for all eternity. And this creates, we'll get to it more in depth later, the ethical dilemma for clergy particularly. Yeah.
It's not real common, but it's increasingly common that someone will get angry and decide to kill a lot of people out of their anger and then kill themselves so they don't have to go through the mess of being tried.
Mm-hmm. That does happen. That is not typical suicidality. That is often attached to other mental health challenges that have usually gone undiagnosed. Or the person has fallen through the cracks in the system and isn't well treated. But that is a fear. But it's usually attached to other types of mental health challenges. So it's not common. Most people who are suicidal have no interest in harming anyone else because they believe your life matters way more than theirs. Yep.
There's just a lot of tension around it, but on the clinical side of things, we do find there's this thing called suicide by cop, and people will agitate to be shot,
right.
And that's actually a suicide. It isn't considered suicide because
absolutely. Suicide by cop is real in the mental health world, particularly for people who have really complicated mental health challenges, who do not want to be alive, but know that if they push cops far enough, they will die. I know in the state of New Hampshire, there is a strong push to have police officers trained in mental health responses and how to avoid using lethal force with someone who really wants you to kill them. I don't know how successful it is. It's a relatively new program. I hope there are other states who are doing it because no cop needs that on their conscience either. He or she made me kill them. Who wants to live with that? You know, I had no choice. I had to shoot them because they were going to shoot someone else or whatever the issue was. Nobody should be put in that position. And we have technology now that allows for the use of force that is not fatal and will stop someone from moving. So they're training, at least in New Hampshire and I hope other places, local police officers to respond differently to mental health situations. All right. Anything else that we think about suicide and the church particularly?
I read recently, and I'm sorry that I can't tell you the source,
That's okay.
but that, and I've heard you use this phrase a couple of times, the phrase of committed suicide,
Mm-hmm.
and that word committed carries a certain amount of shame with it.
Right. It's
For
not,
For the family left,
Right.
that's a hard word, and that
technically that's not a word we're encouraged to use either, committed. I try to avoid using it, but it comes out because I was trained before we had sensitivity to language. Completed suicide, attempted suicide, or suicide as a verb, that person suicided.
or died by suicide.
Died by suicide. We try to avoid qualifiers. It's challenging for those of us who were trained before this sort of sensitive to language came out, but I tried, so thank you for pointing that out. I will continue to try to avoid using that word. Yes?
Another sensitive area in the church is clergy suicide.
Yep.
It seems to be on the rise.
Yes.
Yep. Clergy are in a high-risk group, strangely enough. One of the higher risks of professionals with clergy. And part of that is because clergy don't disclose their own mental health challenges because it is not safe. I have a colleague who had an episode of psychosis due to bipolar disorder because his body chemistry changed. He was taking meds, body chemistry changed. He became psychotic and the church fired him. Straight up, done. Like, wow, that wasn't the most compassionate response. So part of the risk of suicide is that clergy don't disclose. Yeah. Anybody know what the Bible says about suicide? It's one of my favorite questions because almost no one ever knows. It says something. There are 7 suicides mentioned in the Bible. What is not mentioned in the Bible, I can list them for you if you really want to know. Anybody dying to know who they are?
Yeah.
All right.
The pigs.
What?
The pigs.
The pigs, they don't count because they weren't human. And technically that would be
Arguably.
hogicide, swinecide.
But that's the one that I always think of is.
I mean, arguably the demons are committing suicide by
Right.
a cop.
Right, there you go.
Either that or Jesus is committing homicide or pigicide because he's sending them over. No. Poor pigs. All right, there was Abimelech in Judges. Samson, also in Judges. Saul in 1 Samuel. Saul's armor bearer, also in 1 Samuel. Ahithophel in 2 Samuel. Zimri in 1 Kings. And last but not least, Judas in Matthew.
So is Judas the only New Testament suicide?
The only one mentioned, yep. Mm-hmm. And the Bible does not specifically address suicide. Most people assume it is covered under the 6th commandment. You shall not commit murder. The interesting thing, as theology developed around suicide, interesting thing is that the Bible says nothing about God's response. There is no condemnation, there's no judgment, there is simply no indication of God's response. So all the stuff that the church has created around suicide has nothing to do with Scripture. It's all social and power over. Sometimes that's helpful. I mean, if the only thing that's going to keep someone from killing themselves is to believe that it's a sin, I'm all for it. Go ahead and believe that. When you're in a much more stable position, we can talk about a different kind of view of God, but for now, I'm all right with that. But, yeah.
I just have heard of people talk about the scripture, here's life and here's death, choose life, that God even gives choice. People theologically play around with the fact that people believe that.
Yep. You can justify anything.
Yeah.
And people who want to kill themselves will justify it biblically. God says, I can choose life or death, I choose death. Well, that's really not what God meant. God wasn't talking about literal death. God was talking about spiritual death, and we don't want you to choose that either, by the way. So people who are intent on any action can find a biblical justification for it, good, bad, or otherwise. We're really good at that. All right. Any questions at this point? You with me so far? Anybody need more candy? I want to keep everybody happy. All right. So now we're going to move into statistics. Anybody know any statistics around suicide?
White men, yes. The older they are, the more likely.
One of the most at-risk groups, and continuing to become more so, are white men over the age of 65. Have one of the most rapidly increasing rates for suicide. I didn't see that coming, but it's true.
Returning veterans are very high risk.
Returning veterans comprise 22.2% of all suicides.
Wow.
Yeah, they are a huge risk.
What would be the reason for that? Medical or break up families after 4 years of marriage or something?
Oh, the white men? There's a lot of speculation and some reality. Sometimes it is the loss of abilities. You know, in society, I hate to be stereotypical, but it's true, men are still conditioned to be the strong ones, the caretakers, the providers of family. And as you age, inevitably you are less able. And there is ageism in our society.
Sometimes it's loss of identity.
It's loss of identity. If you're diagnosed, well, if you retire and your whole life was your job, then who are you? So that's a risk factor. And then if you have any kind of medical or cognitive changes, some people think that life is over if they can't continue to do the things that they have already done. And men, particularly older men, are not likely to talk about this. Not likely to be all touchy-feely with their emotions. They make a decision and they do it. It's a thing to be aware of.
The only one I knew was my husband's relative. Yeah, was ill. He actually went to the garage with heels.
Yeah.
He didn't want to go through.
Well, there's also the right to choose death with dignity is another conversation that is happening in our country. And sometimes geriatric suicide is just that. And it's hard to separate those things out unless you're looking at it case-by-case basis. And I am a proponent of people having the right to choose death with dignity, especially if you are older and you have a terminal illness. I support that. But that is still marked as suicide. So some of the increase is people choosing to end their life rather than endure whatever illness they have.
Yeah. Black women don't have the same increase as they get older, and they have the same rate of illness. So we can't say that all that is about illness.
It isn't all that. It's there's so many factors that go with social conditioning, cultural. There is, black women have different protective factors than white men. There's so many things that go in and around that we can't say. There's no one cause for suicide in any age group. And sometimes we simply don't know why someone did it. Yeah.
About perhaps a second leading cause of death for our teenage population?
Mm-hmm. It is the second leading cause of death for ages 10 to 24. It is the 10th leading cause of death nationally. Every approximately 13 seconds, an American dies by suicide. Every 13 seconds. That's approximately 40,000 per year. It's the 5th leading cause of death for ages 45 to 59. Native Americans or Native Alaskan adolescents and young adults, ages 15 to 24, have a approximately 2 times higher rate of suicide. LGBT youth are 4 times more likely to attempt suicide. see. For every woman who dies by suicide, 4 men die by suicide. However, women are 3 times more likely to attempt suicide. And that goes back to lethal means. Men tend to be more violent, so more lethal.
I'm sorry, can I ask you to repeat the age group that was 10-year-olds?
10 to 24, it's the second leading cause of death.
I have an obscure question. Do you know if that Native American includes Hawaiian?
I don't know, but I would guess that they were up there, if not a slightly higher risk, because they're isolated.
Where you finding, or is it all over the place? Behind these numbers?
These numbers are based on this 2013 statistics from the CDC. CDC has the most consistent data on these things. There's other people who have them, and it's kind of like, what? Where did you get that number? But CDC, and they're usually 2 years delayed in getting the statistics out there.
CDC is Center
For Disease Control. Yeah.
I'm from South Dakota, and this past year we had more suicides among the Lakota and Dakota people.
Yep.
Young, and even up to 30 years old.
In places of isolation and poverty and increased addiction, there is an increased rate of suicide, and Native reservations have some of the highest rates across all folks. And their contagion is significant. We have a gentleman in my congregation who is Lakota, and he often asks us to pray for the family members of someone who has suicided. So.
And these are youth, though, that I don't think had to do with any kind of drugs or alcohol.
It's the perception of hopelessness, the perception that my life cannot get any better. It is going to be like this or worse forever. Adolescents are not capable of imagining a future different from their own experience. It is the way their brains are, and they're also very impulsive. So if someone says, my life sucks, so I am going to kill myself, it is likely that others will start thinking similarly if they're in a similar situation. And life on reservations is not pleasant. And there is not a sense that it will get better. And there is depression and substance abuse and poverty, and that just increases the risk and the contagion factor. Any other statistics you're interested in? I may or may not have them. Yeah.
When you use the phrase or the word contagion, can you just unpack that in
Sure.
relationship to the disease of suicide?
When we talk about contagion, it isn't contagious in the same way that a cold is contagious. There's not a virus that spreads suicide. We all know that. But for people who are at risk, they are depressed, they are hopeless, they are in extreme psychological pain. If someone they know and love, or if you're a child or an adolescent, you have a classmate who dies by suicide, it increases the likelihood that you will engage in suicidal behavior. That's contagion. And the way we talk about suicide, particularly in the postvention stage, we have to use what we call safe messaging. How do we talk about suicide safely to contain contagion? And churches can play a huge role in that if we are brave enough, because it's really hard. And that's why the language we use is so important. Yeah.
It's also an issue of familial, generational transmission.
Yes, someone who has a family member who has died by suicide has an increased risk right off the bat. Especially a parent. Grandparent is also another risk factor if the family is close. But if you have a history, a family history of suicide, then generations below are at risk. Yeah.
I mean, to add to that, I work with a lot of suicide clients, and what they've told me is, well, not the clients, but the slave driver, is that it's not just the fact that a family member died, but it's that the coping skill learned that a parent would teach you was never shown, so you don't know how to deal with the same thing that they were struggling with as well.
Exactly. It isn't so much just the act of suicide itself, it's the coping skills that have been learned. It is part of the reason why children of alcoholics often become alcoholics, because that was the demonstrated coping skill. Nothing else was offered. So, other comments?
Does that generational factor, like having a parent or a grandparent who died by suicide, how much does that multiply the risk? Is it a weak factor or a pretty strong factor?
Depends on the person and the other life experiences. We know that it's an increased risk factor. I don't know that anyone has actually measured it. But usually, if there is death by suicide in the family, there is either a major mental health issue or a severe addiction issue, or both. And sometimes those are unmedicated, undiagnosed, unacknowledged. So you have, and those things are genetic. So then you now have the genes that make it more likely that you will experience these things. So where it falls on the risk factors probably depends on the other circumstances.
Yeah, I see.
I'm having a hard time, well, not understanding, it's just the concept. You said that, I get it generationally that, future generations, but you mentioned something briefly about if a child has committed suicide, that the parent would be?
Parent is at risk, yes. Because there's many reasons for that. One is our children are not supposed to die before us at any point in life. And the sense of responsibility and self-judgment when your child dies by suicide is overwhelming. And then if you add some other things into that, such as faith belief that that person is in hell, or that you can't live without that child, or the sense that the whole world is blaming you, that increases your risk factor. It doesn't none of these are guarantees. Risk factor does not mean that someone will actually do it, but it's something to pay attention to and be aware of. Yeah.
There's risk after any child death.
Any child death.
It's by suicide is sanctified.
That's correct. That is correct. People are vulnerable to suicide when they are grieving. You are grieving the loss of a loved one.
Especially one that's not supposed to die before you.
Especially one that's not supposed to die, or someone you've been married to for 60 years.
Mm-hmm.
It increases your risk. And that's part of what contributes to older men dying by suicide, is that their lifetime partner has died before them, and that wasn't supposed to happen. Other questions or comments?
In the generational issues, besides the biologic issues of mental health, when a parent suicides, and I especially see this in mothers and daughters, but I think it exists otherwise too, there's the message that's given if you are a child who experiences a parent's death, I'm not worth sticking around for.
Right.
Abandonment issues.
That creates a lot of issues and risk factors in the surviving child, even if that child is a young adult or an adult, because I wasn't enough to keep my parent alive. It's what we tell ourselves. Because we all want our parents to choose us over other things, right? Doesn't matter how old you are. You still want it. Yep. Okay. All right. We're going to move now into a slightly more hopeful topic of prevention. As I mentioned before, I believe that the church has incredible power as an agent for suicide prevention. There's no guarantee, of course, but studies have also shown that people who are active in a faith community have, across the boards, better health outcomes. These are medical studies. They haven't done them with mental health because it's really complicated. But overall, people who are involved in faith communities have better health outcomes. So if you extrapolate a little, it would make sense that if someone were involved in a faith community, their suicide risk would be less than someone who is not involved in a faith community. And there have been some interesting studies that rate which kind of faith community has the highest risk. I don't know how credible they are, but it was interesting. Mainline Protestants are higher than Catholics and higher than Jews. No idea why, but probably the old mythology that surrounds suicide, you're going to hell and all of that, less likely in mainline progressive churches. We tend not to think so much about what God thinks of our action on a daily basis.
And I think mainline for Protestant churches are more individualistic and less communal.
Correct.
Than either Catholicism or Judaism.
That is also correct.
What about evangelical or out there, Pentecostal type churches?
I didn't see studies that included them because there's probably an inaccuracy in reporting, because those folks on the whole, and I know there's differences among them, it's hard to talk about generalities, but usually fundamentalist, evangelical, Pentecostal type churches firmly believe that suicide is a sin and you will truly be damned for eternity. So if members of those communities do die by suicide, they're not likely to say, oh yeah, that was one of ours. So, all right. So who's at risk for suicide? We've talked a little bit about this. When you think of suicide risk, who's the first group of folks who pop into your head? Teenagers. LGBT kids. Children of color. Particularly Native American and Black. And there's increasing numbers of Latino kids at risk as well.
Kids with mental health diagnoses.
I heard kids with mental health diagnoses, Beth.
People that live with depression.
People who live with depression. Yep.
Clergy kids.
Clergy kids, because the pressure to be perfect. Uh-huh. Yeah.
Can I just ask about, in terms of Black statistics, I actually heard opposite, but that it is rising, but it's not a large contingent, but I just want to know more about what
the studies that I showed said that Black boys particularly have a high risk. Now, whether that is due to intentional suicide or accidental overdose or involvement in gang activity or the kinds of things that Black boys are involved in with a higher percentage than boys who are not Black. I don't know. I didn't officially include that statistic because I could not verify the study that showed that, because I had heard that traditionally Black communities were a protective factor because the community tends to be emphasized more if you are in an area where there's a strong Black community. I suspect that the reason that number is probably on the rise is because communities are not what they used to be. You know, people move away, and you could be a Black family living in a white neighborhood with no sense of connection. And there's good things about that, and then there's some increased risk factors about that. Yeah. Nobody knows for sure how much race plays in these things. I have talked to a lot of young adults who are Black and Latino, and they have an increased anxiety and fear based on what's happening in society now with the awareness of systemic racism, mass incarceration, things like that. So I think some of that anxiety is contributing to that sense of hopelessness. And I don't blame them at all. Okay. Who else is at risk?
The elderly.
The elderly.
I don't know how biologically you want to get, but very low cholesterol puts people at risk.
There are some medical conditions that do put people at risk that we don't often think of. Thyroid issues can put people at risk. Low cholesterol puts people at risk. There's some strictly medical risk factors.
Medicine.
And medication can sometimes increase the risk. Yes.
Smoking increases mortality from suicide.
Yep.
People with substance use.
People with substance use and abuse histories. And sometimes those statistics are a bit skewed because there's a lot of accidental overdosing that happens, and an accidental overdose is labeled as suicide. Yeah.
Would you say access to guns?
Access to guns is a contributing factor. If someone is depressed and does not have access to a gun, it is likely that their suicide attempt will be less lethal. Someone who has access to a gun, very few people survive a suicide attempt with a firearm. Very few. And guns are easy to get and will become increasingly more easy with 3D printers. So there is a movement among survivors of suicide to ban guns that are easily accessible. They're very strong proponents of that. That has nothing to do with right to bear arms and all of that.
People who have experienced trauma, like sexual violence and
PTSD of any kind, trauma, sexual violence, childhood trauma, or soldiers, high risk. Because PTSD is one of those things that can sneak up on you at any time, anywhere, and it can overwhelm you. And if you think you've dealt with it and then you have a major episode of PTSD symptoms, you may think, I'm never going to get away from this, and in that moment decide I'm done. Yep.
Totally random offshoot, but they're saying a lot of former NFL players that the nerve
Brain injury.
Yeah, brain injury.
That is a population we don't talk about very much. It's one we need to talk about more because we have a number of soldiers returning with traumatic brain injury. We know that football players, particularly traumatic brain injury, boxers, traumatic brain injury. The more we learn about that, the more we know that these are risk factors for a lot of unhealthy behaviors.
Are certain just areas of employment at certain risk?
High stress jobs have certain risk. Clergy are in a group. Air traffic controllers, higher risk.
ER docs. ER docs.
ER docs. First responders have a higher risk. There's lots of things that put you at some degree of risk. It's true.
Is that because of a feeling of being overwhelmed? You can't do everything.
You can't do everything. Some of it is vicarious trauma. You know, how much death and destruction can one person bear witnessing? Compassion fatigue. I can't do this anymore, and if I can't do this, what can I do? Yep.
What do you know about the, speaking of teenagers, after-school activities, whether it's organized sports or arts, music, theater? What does that do to the risk?
That we don't know about risk reduction so much. We don't talk about risk reduction so much as we talk about increase in protective factors. We want the protective factors to outweigh the risk factors. Somebody can have high risk factors and have enough protective factors to compensate. So it isn't a question of lowering, it's a question of which one is greater. When I worked at the hospital, we had patients who had serious personality disorders and engaged in a lot of self-harming behavior. And the doctors would be worn out with these often young women because their behaviors were increasingly risky. And they would say they wanted to die, but wouldn't do anything that would actually kill them. And so the doctor would just send them home. And I remember more than one, but one specific incident where a young woman who had this long history of constant rehospitalization, and she had a horrible history of self-harm, and she told me, I've given away my cat, my friends don't talk to me anymore, my plant died, I'm not allowed to go to church anymore. If I go home, I will kill myself. And I went to her doctor and said, this young woman is going to kill herself. And the doctor said to me, no, she's not. She hasn't ever yet. Why do you think, you're the gullible chaplain, why do you think that with 32 suicide attempts, she's actually going to do it this time? She has no protective factors left. You've relocated her to a different area, so she has no friends. She is not connected into mental health services. She's given away her cat. She doesn't even have to water her plant anymore. What on earth makes you think she's not going to kill herself? Right. So protective factors are things like being involved with the community, church, protective factor, after-school sports, theater, anything that the person is passionate about that is healthy and age-appropriate can be a protective factor. I know, healthy and age appropriate. My kids in the hospital would always say, you have to say that, don't you? Yes, I do. yes, I do. So when we see a shift in somebody's passion and interest, then that's a warning sign. We've gone from risk factor to warning sign. So the other thing I want to mention for risk, the highest risk period is post-hospitalization. Hospitalization for mental health or hospitalization for surgery. Someone may not be recovering as well as they wanted to. Sometimes surgery can induce depression. Trauma to the physical body can often result in trauma to the psyche. And chronic pain has the same impact on the brain as chronic depression. Brain looks the same for people with chronic depression and chronic pain. Just something to be aware of. All right, so we've talked about who's at risk. Warning signs, what are they? You know some, we've mentioned some.
Talking about it.
Talking about it, definitely a warning sign.
Putting your affairs in order.
Yes.
Giving away your cat.
Putting your affairs in order, talking about
Giving away your things.
giving away your things. I want you to have this thing, but that's your favorite. I know, I just want you to have it. Really?
Increasing isolation.
Increasing isolation. Mm-hmm.
Having a plan.
Having a plan. Having a concrete plan, even if you think it is not a plan that will work. Someone who has a concrete plan, I'm going to go home, I'm going to do this, and I'm going to do this, and then I will be dead. Big, big warning sign. Yeah.
A new sense of calmness.
Yes, that change. You've known someone to be depressed or anxious or withdrawn, and all of a sudden you see a mood change. That can't
even
be
if it's positive.
Yes, even a positive change, because that could mean A, the medication is finally kicked in, they're feeling better, or B, they've decided, I'm going to do this. And that's when you ask the question, what are you thinking about suicide? Have you thought about suicide? If the answer is yes, your next question is, do you have a plan? And then your third question is, will you go with me to the emergency room? Yes. And if they say no, there is nothing wrong in calling 911. If you believe that someone is at risk for suicide, you call 911. It is not up to any of us to assess that risk. Yep.
Can I push back on, not that I'm not standing there right with you, but our mental health system sucks.
Yes, it does.
But I was trying to say that before my kid walked back into the room, but it is a struggle. Oh, you know, serving as a hospital chaplain for many years, serving as a pastor, standing with people who are in those positions. Okay, we're there. I hear your story. I want to make my story part of your story. Let's go. We go. I mean, either the resources are brutal, or the response is negligent, and the end result is great. I have a bill. I have no answers, and I'm 3 steps deeper than when I started. What's your panacea there?
Yeah, hold on. Did you have a comment on that? I saw your hand up, and you sound like a clinician. So.
I know, I'm like, and I agree. I'm in a facility where they're released to us before they go home, so they're like that 3
that transition,
nice.
Yeah, because
nice.
they just can't go back home.
Nice.
And so the initial psychiatric holds are rough, maybe not so great. I never worked in them, but we do get the kids after.
Right.
Yeah.
But I will say, as just like a lay person, I would never want to not take somebody's
Oh, of
depression.
course.
So I'm like, I get you, but I'm like,
of course. It's not an either or.
Yeah.
It's how come we can't get a both and?
That's right, that's right.
In that same thing, there's folks on the other end who, when you call for help, you call for the emergency room, like the cops, or others who can be easily argued out of the idea that this person is a harm to themselves.
Right.
Especially in mania. So many.
Right.
So many.
There's
This person's not hurting anybody.
our mental health system is broken in many, many ways. However, we don't have a better option. If you believe someone is at imminent risk, you take them to the emergency room, you meet them there, you call 911, you do whatever. And even if that is a poor experience, you have at least got them to think about something other than killing themselves. And hopefully that thought has been derailed, at least temporarily, and then there can be other things put in place. Can I help you find a therapist? Because you need to talk to somebody. And as a pastor, most of us are not qualified. Clergy are not generally qualified. Some of us are, and we still shouldn't do it because we're pastor. Can I help you find a therapist? You know, can I check in with you? And that's where knowing our own limits comes in handy. What are you able to do for someone who is at risk for suicide after you have had them assessed by a clinical professional? Whether that has been a positive experience or not. No one who ever goes to the hospital for suicidality is saying that was the best experience ever. They're either pissed because people did not cure them, or they're pissed because they're not dead. But they're alive to be pissed at you.
Right.
Excellent.
And there is a message of somebody cared enough.
Right.
To.
Right. I took you seriously. I believe that you do not want to live with this pain. Absolutely.
I just want to follow up in case people think that I'm a recluse, but
You're not.
A big part of the work that I seem to do in my parish with my congregation now is with families who are distraught and disappointed because the system failed them, and their person completed suicide or it has less traction than when they started.
Yep.
That they trusted the system failed them. You know, there was no bed, there was no holding system, there was no step down, those sorts of things.
Yep.
Yeah.
And that's where faith community can be somewhat helpful, because you're not necessarily providing therapy, but you're providing connection to community. If you have a congregational care team by whatever name, you can set it up so that that person who has recently had a suicide attempt or has expressed the desire to kill themselves can have contact with someone in the congregation who will bring a meal. Because, you know, mental health is the no casserole illness. Suicidality is more so. So as pastor, you don't necessarily have to tell if the person isn't willing for others to know. This person needs extra congregational care. Can you put them on your list of, you know, to bring dinner over to make a phone call? You know, a couple of times a week by a variety of people can make a difference, because here's a community that cares about me and wants me alive. Is it a guarantee? No. Does it increase protective factor? Yes. And that's what we're all about.
I appreciate you saying it, because just being on the other end of things, I'm in the church, but I'm in the therapy side of things. I always tell my families, they come to us like, fix my child, because we're the professionals. But I will tell them that the professionals have less attachment to your child than the churches do. Like, they're a number, we have a treatment plan, 3-week funding, and then we go. So it is more.
Right. And if you are a church member and you go to your pastor on behalf of another church member who has someone in their family who's at risk, and that pastor is not responsive, then you call that pastor to accountability. You go to your governing board and say, there's a problem here. Because this is a problem in our congregation, and we have a pastor who's not willing to deal with that. What are we going to do about that? Because most clergy can go through seminary without ever taking a class in mental health care, for one, or suicide and response for 2. Like, I don't know how that happens in 2015, that people can go through seminary and not have these things, but it's true. So the expectation that our pastors know what to say in the case of suicidality is generally not true. And I want to make sure that we get to the postvention side. We've talked a little bit about prevention, talked about a little bit about intervention. You know, you take every threat seriously because you are not a clinician. Even if you know that person has said this 1,000 times and they have been in and out of hospital for suicide attempts, you take it seriously, because you never know when that person will die because they didn't get the attention they needed in that moment. Because all human behavior is motivated by getting our needs met. And people who have chronic suicidal behavior have learned very unfortunate, ineffective ways of getting their needs met. I had patients, the only time anybody ever put hands physically on them was when they needed medical intervention because they had harmed themselves in some way. That is a horrible, awful way to live. So people say someone who's suicidal is just manipulative or attention seeking. Damn right. Give it to them. They need attention, and that attention will save their life. Give it to them. If my church had not responded to me when I had attempted suicide, I guarantee the next time I did it, I would have died. They saved my life. You have the potential to save other people's lives. Take it seriously. All right. Any questions before we move to postvention? Because I know a lot of you are here for that. Anybody ever heard the concept of postvention before? Some.
Said like that, not in those words.
It is come out of the Suicide Prevention Research Center, SPs, I don't know. But I learned about it when I served on the State Suicide Prevention Council because a lot of New Hampshire is very rural, and contagion was a huge risk factor. You know, you have uneducated folks living in poverty with a lot of substance abuse. Kids don't believe that they can grow up and do better than their parents did. And they look at their parents and say, I don't want to be them. A lot of undiagnosed mental health issues, all kinds of stuff going on out there in the world that we don't attend to very well. So the idea of postvention really focused on what we do in response to a suicide so that we minimize contagion and we give people the care and attention that they need. I know in New Hampshire and some other states, the crisis response team for the state is trained in suicide postvention. And they are called to schools, to things that happen like murder, suicide, stuff like that, to help communities cope. Churches can be very effective at helping communities cope if we have safe messaging. And safe messaging refers to that language we use around suicide. We don't talk about success or failure. We don't talk about it's a sin or God loves everyone and that person is completely free and at peace. I know that is a mistake I made as a young person who was new to ministry, and no one ever told me don't say that, because I really wanted those suffering family members to feel better. I was really lucky that no one else died after I did services like those, because they could have. And one of the overall protective factors of society that has decreased is the decrease in religious commitments, faith community involvement, means that less people think about what God thinks. So suicide is less of a taboo in society, and people confuse it with the right to die with dignity. So there's a whole lot of stuff that is shifting that puts more people at risk because there is a decrease in protective factor. We want to increase those factors for the members of our congregations and the community around us. That's the tricky part. So for the clergy in the room, you have to sort out your own feelings and beliefs around suicide. You have to know very clearly what you believe. I do not believe suicide is a sin. I do believe in a forgiving God. But when I am meeting with a family after a suicide, I'm going to get them to tell me what they believe so that I can uphold the protective factors that they come with and navigate the risk factors that they come with, which is why I say God is decidedly not a fan of suicide. It says nothing about condemnation. It says nothing about freedom and peace. It is a middle of the road. God is not a fan. Leaves people where they're at so that you can work with increasing protective factors, decreasing risk factors. And it gets a little tricky because how do you preach at a memorial service for someone who has died by suicide? One, you have to be respectful of the family, but that's where the education piece come in. I highly recommend that if you are doing a memorial service, that you speak about the cause of death. You never, ever talk about the means. Ever. Do not ever talk publicly about the means of someone's suicide. Don't do it. But name it. But also celebrate the person's life as it was. Because people are more than their mental health issues. People are more than their death by suicide. But death by suicide is something that needs to be named. Name it. But also, if you have printed material, put in the local resources for people who are at risk. Put in the suicide hotline number. Put in your local hotline number. Put in your crisis center number. Whatever is available in your local community should go in there. And make a clear statement that we worship a God of hope, a God who loves all human beings, and that there is hope for every person. Whatever else your message may contain, that's where you go. So that someone who is at risk because their loved one has died or their classmate has died by suicide, you can give a message of hope that might increase the protective factor. Because even though I think I suck, maybe there's hope for me. It's possible that maybe God loves even me. So you want to increase that. Yeah.
Just if a family is saying, no, we do not want to say it's suicide, do you push or do you just?
I push a little bit, but it depends on your own comfort level. Because I say we don't want this to happen to any other family. And if you are willing to risk talking about it, naming it, I promise you we will not give any details. But if you are willing to take that risk, it increases the likelihood that others will be safer. And people want to protect others from the pain they're going through. Because there is no greater pain for loved ones than someone who dies by suicide. Because the guilt, the confused emotions, if I had only, I wish I could have, I wish. Yeah.
In this context, can you talk more about hope, what that looks like, feels like?
Mm-hmm. It goes back to where I started. Who are you? You are a beloved child of God, even if you don't feel like it. Where do you belong? In a loving, caring faith community, even if your family of origin is not that way. When we talk about widening our welcome, that's what we're talking about. You are welcome here. We want you here. We want to know you. We want you to feel part of this community. We want you to feel connected and have a purpose. Where is the hope? Jesus loves you. And because Jesus loved you, we love you. We are called to embody Christian love. That is the church, the body of Christ, the hands, feet, and voice of Christ. Don't be afraid to say that. Claim that. We're not really good at it in mainline Protestant churches because we are God's frozen chosen. And we're like, yeah, Jesus loves you. Somebody should love you.
I found that hope was the determining factor for me, because I've had, since 9th grade, I've had suicidal thoughts. Not now, fortunately, but I found that there were some people that held out hope for me when I could not hold on to hope any longer. And I trusted them to hold the hope for me so that I could get through the next 5 minutes or 10 minutes or whatever. And it's really powerful to hold out hope for somebody and affirm their value and your care. And as Valerie was saying, I see you.
Right.
I see you.
I see
right
you.
As you are.
And I have hope for you.
Yeah.
And that's true. To become a bearer of hope for someone who cannot bear it for themselves there is no greater calling, because that person's life is right there. And you can help them claim it for themselves.
This, what you said about naming the suicide, it seems to be key to unraveling or beginning to unravel all the shame that goes with it.
Exactly.
Just amplify a little bit on the mechanism by which naming it could make others safer. I'd just like to hear a little more about that. I think that's so important.
It is, mental health is the last taboo of the Christian church. We don't talk about it. We're uncomfortable talking about it, we deny it. Because there's still that sense if we pray enough, if we have the right faith, if we do the right thing, there's no mental health issues. So suicide is a very clear statement, there's mental health issues here. Very clear. And if we are brave enough to talk about suicide, the shame that people carry around it decreases, because you know what, we can talk about that in church, it can't be that bad. If I say suicide in church and the roof doesn't fall in on my head, lightning doesn't strike the steeple, maybe it's okay that I talk about this. Maybe I don't have to keep the secret that someone I know and loved died by suicide. Maybe I don't have to keep the secret that I have thought about it more than once. So by naming it, you say it out loud, you decrease the shame and the secrecy. I saw another hand. Yeah. Okay, go ahead.
Can I argue a little bit about
You can argue about anything you like.
the necessary response is to go to an emergency room?
It depends on.
Can I?
Yep.
I'm saying that as a psychiatrist.
Yep.
And my question is that while depression is a medical illness, not all suicide is helpfully medicalized.
Correct.
There are existential issues going on sometimes. And I don't want to argue that the only option is to put someone through a suicidal assessment by a mental health professional.
Right.
I'm pretty comfortable if someone who you know is willing to have you in their house and we agree that there are no guns in the house and bottles of medicine are put away and you're not dumb enough to think that aspirin isn't a medicine, that often in 2 or 3 days things look a lot different.
Right.
And you haven't traumatized someone by putting them through this ER thing, but you have communicated your care for them.
Yeah. And that, I would do that, but I've spent a lot of years as a mental health professional. I know a lot of clergy are very uncomfortable having that conversation. So unless you have received training around that, that might not be your best bet. But yes, if someone can, as we say, contract for safety, they can give you any lethal means they have. They will, I get people to do it in writing. They will write down that they promise not to kill themselves without calling you first, then I will do that. But if you don't know enough, or you don't want the responsibility because you don't know enough, or you know you're leaving town, then yes, the ER is the answer. It depends. When I talk about knowing your limits, knowing your experiences, knowing your resources, that is key. Because you're messing with someone else's life. If you know that you have the resources to help someone get through those couple of days until their mood shifts, then you can do that. If you don't have experience or resources or someone you can call and ask for advice, don't do it. So yes, I agree with you, but it's a qualified agreement depending on the experience of the person doing the intervention.
Where does our clergy responsibility as mandatory reporters intersect with what you just said?
Is it the state level? Like, I think it's state. I don't know if it's federal.
You are not mandated to report someone who says they're suicidal.
In Colorado, you are. You have to.
Some states,
If you're
clergy,
a health professional.
Or passive clergy are now.
depends on what state you're in. If you are a mandatory reporter for suicidality, then you have to weigh out, is this person imminently at risk? Or is this person expressing to me a thought that can be mitigated until we find a more effective coping? And again, that depends on your experience, your knowledge, your resources as a pastor. If you really believe that person is going to kill themselves as soon as you walk out the door, then you don't hesitate. You report. There's no, like most things in mental health, there are no hard and fast rules. And the things that I have said about what to do when, I am assuming that most people in the room do not have advanced training and have limited experience. So I agree with you 100%. If you can avoid sending someone to the emergency room, particularly in rural areas, please do that. But if you are not equipped emotionally, educationally, time-wise, get them to some place, because it will at least break the cycle. They're not going to be happy, and they might yell at you the next time you talk to them, but they'll be alive. Yeah.
I have a question. Do psychiatrists really know? Because my son was good at telling you what you wanted to hear. So can they differentiate that?
Psychologists, psychiatrists, therapists of any kind, I would always tell my patients, I am only as good as the information you give me. If you do not tell me things, there's probably a likelihood I'm not going to be able to help. I can make guesses, and there are warning signs that psychiatrists, psychologists, therapists can notice and raise questions, and it also depends on the age of the individual, what you can do. But it's not an exact science. Do you want to say more as a psychiatrist? I'd hate to put you on the spot, but you identified yourself as a psychiatrist, so, and I know that you're a very caring and committed psychiatrist, so.
We spend a lot of time on that question, like how much can you really figure out? And it does finally come down to counting risk factors and protective factors. And I actually put very little credence in what the person tells me. I count up the risk factors and I count up the protective factors, and I look at what options there are for caring for this person. If I come to the conclusion that this person is really depressed as heck and we need to get him on meds, I'm pretty quick to say you've got to be in the hospital, because that's not something I can ask family members to deal with. But if the real issue is I just flunked my final exam, and I had counted all my life that I was going to be this, and now I flunked the exam, and it's not going to happen. That's actually not the question. That's actually an existential issue. And there's two family members who say, yeah, we'll go home with them. Someone will be up with them all the time. We'll give this some time to work its way through. That's not depression, that's not a medical issue. It's a bad idea to make it a medical issue. But if the risk factors are high, I'll make it a medical issue and insist that they go in the hospital.
But then the other problem is the hospital says your time's up, you gotta go.
No, the hospital doesn't say that.
The insurance company says that.
And then like 2 days before, they say, I want to commit suicide. Well, you still gotta go. And
Right.
then where do they go?
You go back to the hospital, and
That's another story.
Insurance and mental health is a whole
Yeah.
bundle of a nightmare for mental health professionals and hospitals who are trying to provide care for people who need it. There's limits, there's stuff that just makes your head spin. So, but I do know, I have witnessed many doctors on the phone with the insurance company saying, no, you will pay for this and we will keep this child here or this person here until they are appropriate for discharge. So I know with managed care that has all shifted and it's complicated, but if a person really needs hospitalization, there are ways to get it.
I was just saying quickly that when therapy, something that's really helpful with people is I talk about and build their self-esteem, and it seems kind of ironic, but it's not so much grieving. I think that's a different type, but things like character traits. So not you're good at basketball or you like pizza, but like you're savvy and assertive and quiet. And I like literally just talk about their character traits like 6 months at a time, because it gives an identity, and that has worked a lot. Just a personal sense of self.
Right. And people who are at risk for suicide, that sense of self is fractured, whether through an existential crisis or a mental health crisis. That sense of self is fractured by something. And if you can work to build that up.
Churches can do that.
And churches can do that because you say, we've noticed you have a gift for this.
Yeah.
Would you share it with us? Like that. I had a client at the hospital for a number of years who she was discharged, and she lives out in a rural area and she belongs to a really small church, but they gave her the ministry of greeting cards because she had this love of sending people cards. So why not make this her task? Very simple, perfect, done.
Well, that's what I always say is for anybody in life is to inspire a person and motivate them to then put their actions into words. In other words, somebody's in doldrums or somebody, even if it's mental health and needs medication, still needs motivation and inspiration. And you need to put action and take their hand and say, well, instead of saying like, make cards, bring them and see if that's what they want to do. Would that help? Or?
You have to be careful with a person's autonomy.
Okay.
You don't want to force anybody into anything, but
No,
you
I
can
know.
have the conversation. I've noticed that you like doing this.
Yeah, okay.
Would you like to do it on behalf of the congregation?
Okay.
And wanting someone to have motivation is good. Helping them find their own motivation is the challenge.
Well, that's what I meant.
Yeah.
You always have second thoughts after you say something out loud.
Yes, I wouldn't know anything about that.
So here's my second thought. If I got an adolescent girl, and there is any chance at all that really what's going on here is she's being abused at home, then everything I just said isn't true.
Right.
Yep.
That person, more than anything, needs to be in the hospital long enough that they can see
Right.
what's going on. But if we're talking about an adult, we're in a different picture.
Right, you always want to check with the are you safe in your own home factor. That's one thing we didn't talk much about at all, but thank you for bringing that up.
And relative to insurance, it takes me about 3.5 minutes after the insurance company tells me no to find out the state representative of the family.
Yep.
And I go to the family and say, this is your state representative's number, and surprisingly, the insurance company is much more interested in what he has to say than what I have to say, so please call him up.
Excellent. So you can recommend that to your doctors if need be. All right, I'm mindful of our time. I show that we have 2 minutes left. Any last questions or comments, or gosh, I really wish you had said something about this. Yeah.
I have a comment, and that is, you might have drawn the short straw, which made you have to do this workshop, but I think we drew the perfect straw.